Thank you very much, and welcome everyone. It's really nice to see such a crowd here still this third morning. This is probably not the sexiest topic, so I am really pleased to see that everyone is here. We think it's obviously a very important topic, and we know that there are a lot of different types of surveillance that are necessary to inform public health, to inform public policy, and to help us determine the resources that we need for prevention and treatment and ways in which we can hopefully mitigate some of the concerns that may come up in a very rapidly changing policy environment. I think that cannabis surveillance is particularly challenging because both the speed of the changes that are happening and as we've been hearing about the nuances of the laws and in the ways in which they're implemented, which are likely to produce very different outcomes. And so it becomes very important to be tracking all of these things and to provide data. The fact that this is happening so fast also means that we needed baseline data yesterday. And while we do have federal surveys and we do have states that have been doing surveys for a number of years, we're not necessarily getting answers to all of the questions that we really need to know. We have other problems, like there are no agreed upon standards of measurement. The products are changing. People that are using cannabis products are using them for different reasons. They're using different products. People of different ages are using different products. So this is a very challenging area to do surveillance in. And all of this, as we've heard, is happening in a much larger political and economic context that, that also is influencing how policies are developing. So it's incredibly important that we are able to provide data that is objective and that is useful to a variety of people who are implementing different public health policies within the states. And I'm very glad that we have such a diverse group of people here today representing these interests. So with that, the way we've decided to do this is that we're going to do a question and answer among the panel, and at the end, if there is some time left, we'll also take questions from the audience. But I'd like to give the panelists a second to introduce themselves, and then we will start the questions.
Thanks, Susan. My name's Gillian Schauer, and I'm a senior consultant to the National Institute on Drug Abuse and the Centers for Disease Control and Prevention.
Hi, I'm Dr. Althea Grant-Lenzy. I'm a senior advisor for science for the Deputy Director for Non-Infectious Disease. I had to pause because we change our name all the time. At the Centers for Disease Control and Prevention, and there I coordinate our work around cannabis.
I'm Julia Dilley from the state of Oregon, a senior research scientist. I'm sitting up here today as a co-chair for the Council of State and Territorial Epidemiologists Marijuana Surveillance Subcommittee.
Good morning, Hanan Abramovici, Senior Science Advisor in the Cannabis Legalization and Regulation Branch at Health Canada.
Okay, thank you. So I think one of the things you realize is that we do have we have people that are coming into this with very different perspectives, so I think this will be an interesting discussion. So why don't we just start out talking about why surveillance for cannabis is important in this current legal climate.
Thanks, Susan.
Changing climate.
Yeah, so from a Canadian perspective, surveillance and monitoring is really important for a number of different reasons. One of the reasons is that in the summer of 2016, when we started this journey of legalization and regulation of cannabis in Canada, the Canadian federal government struck a task force whose purpose it was to advise the government on a framework for legalizing and regulating cannabis. And the task force submitted a report on how to do this, and in that report they had over 80 recommendations, and one of the recommendations, or a couple of the recommendations, were that Canada have a robust surveillance and monitoring system in place, and two, that it conduct surveillance and monitoring in order to determine the impact of legalization and regulation on a number of different outcomes. And that leads me to the second point, which is in our legislation, the Cannabis Act. That legislation has essentially two key priorities: to protect public health and public safety, and there are a number of sub-objectives to that act. Having surveillance and monitoring will really help to understand what the impacts of legalization are on public health and public safety. We also, in our act, have a mandate to report back to Parliament after a certain number of years upon which cannabis is legalized. So we need that data to be able to report back to Parliament and to say, has this initiative been successful? Has it not been successful? If so, in either case, what went well, what went wrong?
Julia?
Thanks. So from a state perspective, the folks working in public health in state and county health departments are using data all the time for planning programs and designing campaigns and understanding where the public health burden is and what the disparities are. So if you're in a state or a county where legalization is being contemplated or implemented, and if you haven't gotten the email yet that says, where's our state's data or where's our data, then you should check your spam filter, because that email is definitely coming. And in the absence of any kind of state or local-based surveillance data, we're fortunate to have very strong national data, so we can definitely use that to set the national context and to get a sense of where we are at with regard to the nation. But I want to make a pitch for as much state-specific surveillance as possible for a couple of different reasons. One is your state survey data are usually available a little bit faster, so they'll give you a better sense of the most current status of your state or locality. Second is the state data sets are usually designed to be more representative of your state or your local entity. So the national surveys will pick up folks in different states, but they're usually not designed specific to your state to be representative and give enough information about specific populations. And then third, your state systems can be more flexible, so you can adapt them and include the highest priority questions for your own stakeholders.
So thank you. So given the challenges of developing these different surveillance tools and some of the compromises that have to be made with respect to costs and burden, what do you think are the most important domains and indicators that we need, and what are and how do we prioritize those?
So from the federal context, as has been mentioned in the United States, we have a number of surveys that do ask questions about cannabis use. I think there are some limitations to those, however. Increasingly, many of those questions are a bit out of date. Updating those questions is quite a process. Unlike Canada, we do not have a federal mandate or federal funding for cannabis surveillance in the US. So as Julia said, I think that makes state-based surveillance increasingly important because of that. However, we've learned that states have developed their surveillance organically, with each state really figuring out on their own what are the right indicators, how do we ask these questions, and that's the prime reason that I helped facilitate a federal state coalition to really think about what should the key cannabis indicators be that we are recommending that states use. And we came up with 9 for adults. Past 30-day use, or number of days used in the past 30, mode or method of use, so smoked, vaped, etc., amount used, type of product used or product characteristics, notably CBD, THC products, reason for use, is it medical, non-medical, or both, cannabis use disorder, secondhand marijuana smoke exposure, household exposure to any marijuana, and impaired driving. We have a separate list of measures for specific populations that you can hear more about this afternoon, including youth, medical users, and pregnant women. And we have secondary measures that we've offered to states as well. Now, I will say one of the challenging things in prioritizing these is how they've been operationalized. And I'll talk in a little bit about some of the limitations, but in short, we really don't have good, well-tested, well-developed, validated questions for a lot of these. For example, if we just look at CBD and THC, we know that most users actually can't report whether they're using a high CBD or high THC product, and they often misreport the THC content. So there are a lot of opportunities, not just to say these are the right indicators, but to look at how we operationalize those.
And I think also, depending upon how things are changing in the states and the policies that are there, if they're better labeled, then some of these things will also be changing and will make some of these surveillance efforts a lot more accurate. Hanan, do you want to say something?
Yeah, from a Canadian perspective, when we first started again down this journey, there were 3 ministers that were tasked with legalizing cannabis in Canada. The Department of Health, Health Canada, which is where I work, the Department of Justice, and the Department of Public Safety. And we kind of sat around and tried to but find out or map out the different indicators that we thought would be important. And the starting point was, what are we already collecting? What are we already collecting through all of our surveys, through all of our databases? What are the things that we're tracking? And that was the starting point, realizing, of course, that we need to expand what indicators we were interested in looking at based on the evolving legislation, the regulations, the objectives of the legislation, which are to protect public health and safety, to protect youth, to dampen the illicit market, to ensure a safe supply chain for cannabis, and to raise awareness and to educate Canadians on the health risks of cannabis. So we expanded that initial list of indicators to try to cover these areas. And then we also consulted a lot with scientific experts in surveillance and research to validate these indicators, to help prioritize them. And so we did that in a couple of different workshops sponsored by our Canadian Institutes of Health Research to try to prioritize indicators and also to determine which indicators are feasible to do, which ones are not. Obviously, like everybody else, we have restrictions around what kind of data we can collect, funding to collect that data. So all of those considerations factor into how we prioritize our indicators.
And I think one of the other important issues, and one of the reasons why it's good to have somebody from Canada on this panel, is that to the extent possible, we need to be harmonizing measures. So we need to be collecting similar data and be able to sort of put that in the context of the policies that are being implemented. So I think it's very important that we keep talking to each other. What do you think are some of the best data surveillance systems that are available now, and what are some of those limitations associated with them?
So this is a question that's, I guess, near and dear to my heart because about, 5 years ago when I embarked on working on cannabis, I was given the following directions. We need to improve surveillance. You have no data, no staff, no money, and no mandate. You have no office and no division to work in. And I want you to, focus on what CDC can do to improve surveillance. So given that mandate, I think that we started with what I think was probably the best place for us to start with federal level surveillance. One of the things that we usually do is leverage existing surveillance systems. So we, like other agencies like NIDA and SAMHSA and others, leveraged our existing behavioral health population-based surveillance system. So NIDA has Monitoring the Future, SAMHSA has the National Survey on Drug Use and Health, and CDC has a whole list, including the behavioral risk factor surveillance, the youth behavioral risk factor surveillance, and others. Why I think that was the right decision, I'm not saying I did the right thing, but why I think that was the right decision is because there were several advantages to that. One, all of those systems, because cannabis use does not happen in isolation. We're talking about people with other comorbidities, other behavioral risk factors. All of those systems collect information about those other risk factors, so that allows researchers and public health folks to analyze other things that may be going on with the individual and other outcomes that they may have. The second is cost. It is very expensive to start a standalone surveillance system. It is tons easier to add 1 or 2 questions to an existing surveillance system. So the marginal cost of adding surveillance to a whole bunch of systems is a lot less. The third is you already have infrastructure. So I was given that mandate in not a lot of time. And so if you had to build a standalone surveillance system that had to collect information, it would take years to stand it up. If you have an existing infrastructure that you can use, you can think of a question, test it, and have it out the same year and have data within a year. So I think those were the things that were advantageous. I'm also going to say from the federal side, there are some limitations to what we do as an approach. One of the limitations is because these are existing huge surveillance systems that already have tons of questions, it takes an act of God to argue that your question is so important it should be included, and so therefore you can only ask usually 1 or 2 questions in that surveillance system, so that really limits what you can ask. And secondly, these systems have been going on for decades, and they're trying to monitor trends over time. So if you have a better way to word one of their existing questions, again, it takes an act of Congress to change the wording to be flexible. And cannabis is an emerging and flexible area where we actually do need to change questions every year. So I just want to throw that out as one of the limitations of what we do at the national level.
So just a comment, because NIDA does Monitoring the Future, which is the survey of 8th, 10th, and 12th graders. And we have a little bit more flexibility there because that's actually done as a grant mechanism. And so we don't have to go through all of the same processes to try and change a question. And we have been able to add questions in a much more timely, a much more time-sensitive fashion. I think the problem with Monitoring the Future is that there's so much data being collected that's not being analyzed. And so I would just sort of make a plea to people to actually try to look into getting a hold of some of those data. These data are to be made available to other researchers, and I think there is really a treasure trove of information in there that actually we don't do the analysis on, and that would be helpful for us in better understanding a number of different areas, but particularly around marijuana.
So from the state perspective, I'll just share that our CSTE Marijuana Surveillance Subcommittee has been bringing together folks working at the state level who are doing surveillance, and we're trying to develop sort of a practice-based evidence. So based on the experience folks are having, what is working, what is meaningful and useful, and what's less meaningful and useful. And I just want to second what these guys have already said, that the existing surveillance systems within states are definitely the place to start as the best place to get information. So the behavioral risk factor surveillance system, school-based youth behavior surveys, and the pregnancy risk assessment monitoring system. So within states, it doesn't take an act of God to add or change questions, but it does take sort of a minor miracle. And so when you're in the position of wanting to add some questions, I really encourage you to turn to the list that Gillian's been leading the development of. So there's a short list of candidate questions to include, but you're also going to need some stakeholder support, because in many states there's a sort of a process for adding, and you have to go and make the case that we need cannabis surveillance questions just as much as we need flu shot questions and other kinds of questions that are also very important for public health. And even though it is very much more cost effective to add questions onto those surveys rather than to build new ones, it's still fairly expensive, and most states are charging per question within your state, so it can be multiple thousands of dollars to add, even 2 or 3 questions onto your behavior risk factor survey.
Thank you. So could we talk a little bit more about some of the limitations to the surveys, and particularly to developing some of these newer indicators that reflect current use practices?
So I want to elaborate a little bit more on cognitive testing. And for those of you who haven't heard of that or don't know what that is, it's really cognitive qualitative interviews with participants who answer the quantitative question. And then you follow up to understand how did they interpret the concepts, how did they arrive at their answer. And what the reality is for cannabis questions is very few of them have been cognitively tested. And as we've started to do cognitive testing, we are actually learning that in many cases what we thought we were asking about is not what we were asking about. So, driving, for example, I think every state has been asking a different question for impaired driving. We started to cognitively test those and very quickly understood people have too many variables here and they can't provide a valid answer. So I think getting funding, not just to field the surveys, which is, as you heard, challenging federally and at the state level, but funding to develop indicators and test indicators is a huge limitation. And we're working in concert with Canada to figure out how can we pool resources and do some of this important work. I would also point to unifying the wording across questions, and that's been a struggle as we land on a good question. Like right now we've got a pretty good question for mode and method of use. We have a number of states who say, well, gosh, we are beholden to our trends, and so it's really going to be hard for us to make a change to this. I think the dynamic marketplace is also challenging. We are already delayed in what we're asking about, and by the time we get questions tested and fielded and data in, the products are already different. So living in that space is a challenge. And then finally, survey modes. I think our surveys, for the most part in states and federally in the US, are phone-based, household-based, or paper and pencil. And we would really be in a better position if we could use pictures, use web-based approaches, both to reach the main populations using cannabis and to be asking questions with the right skip patterns.
Julia, did you want to say something?
Yeah, thank you. So in some of the limitations to cannabis surveillance work, I wanted to talk about 4 things where I had a limitation but also maybe a solution or an idea. So not having resources early on is a key limitation. The story Althea told is exactly the experience that we've had, many of us at the state level or local level. and most of those places you don't have anything to work with as you get started. So using those existing lists that Gillian has identified, and working collaboratively with other states and consulting with one another about what's worked best, definitely the way to go for that. Another limitation is the coordination is hard within states. Unlike other topics, this has been a funny one in that people who have key data sources that you need access to all seem to sit in different agencies and different buildings, and it's very difficult to get everyone's attention and bring everyone together. So a solution that has worked for us in Oregon is to have a high-level leader who's a real champion for surveillance and can make that a priority for folks and getting folks together and spending time on it. We've also mentioned not having enough space on surveys to get the information that you need or get enough information from specific types of populations. In some of the states, we've set up parallel data collection systems to sort of enhance or complement the established surveillance system. So for example, in Washington State, they designed a new surveillance system for young adult behaviors. In Oregon, we're using an online panel survey to complement our BRFIS and ask more of the detailed questions about cannabis use that we can't fit onto our BRFIS. And then the last challenge, which has already come up, is what is most important to measure? And I feel like this is really tough, particularly with regard to the health outcomes associated with cannabis use, because the evidence base is mixed right now. For some of us in surveillance, we're sort of monitoring everything and starting to wait and see what happens. So yeah, that's just kind of what we have to do for now. And I think continuing to share among our peers about what we're seeing and what we think it means is just critically important.
Did you want to make?
Yeah, I could just really quickly, one of the advantages of being at the end is that, you know, everybody said everything that needed to be said already. Just a couple of perspectives from Canada really quickly. You know, some of the data, some of the surveillance data lies at the provincial level. And so if we want, you know, at the federal level, if we want access to some of that data, we need to, A, know what kind of data provinces and territories are collecting, B, get them on board to share their data, have to put together data sharing agreements. That can take a lot of time. It can take a lot of time to come to an agreement about what kind of data will be shared, how, when, and so on. And also, you know, different provinces and territories might be doing different, measuring different things. So it's harmonizing and standardizing the data across all the different provinces, getting them to report similar things so that we can all speak the same language. And I can come back to that a little bit later in another question as an example of that. And the one last challenge really quickly, Indigenous data. So we're trying to get more and more data on the impacts of cannabis, you know, patterns of use, behaviors, all that amongst our Indigenous population, and that's a challenge for us right now.
Yeah, I think the other issue, which Althea has already alluded to, is that I think most of us are interested not just in cannabis use and the health impacts, but also we recognize that this is part of a pattern of other sorts of either substance use behaviors, or there's a lot of concerns about the linkage between cannabis and mental health. And so again, being able to somehow cross-talk some of these surveys so that we can try and get some sense of how these things relate to each other, because it's important that we can see the big picture and that cannabis is not just happening in isolation. I think that, so what do you think are some of the most important emerging areas where we need to be collecting more data given all the changes that are happening?
So we've been having a lot of discussions recently around some vulnerable populations that we're really concerned about at CDC. You know, I mentioned before, we all have Monitoring the Future, YRBS, NISDA, who have great information on youth, and we're concerned about youth, and we know that policymakers are watching youth. But one of the populations that we don't have very good data on at all is pregnant women. And we know that that's a priority population for a lot of the states. Now, if you looked at the recent NISDA data, it suggests that the temporal trend is that the rate of marijuana use among pregnant women may be doubling. That would be very concerning if it turns out that that is true. Unfortunately, it's hard for us to really know if it's true because there's so many limitations right now to how we collect data on pregnant women. Julia mentioned that we have PRAMS, which is called the Pregnancy Risk Assessment Monitoring System in some states. Come to our session in the afternoon, you'll learn that it's not in most states, so we have a lot of limitations to the way we collect data on pregnant women. And it's actually a much more challenging area. I worked in reproductive health for many, many years, and I find that it's a much more challenging area because although we're collecting information from the pregnant women, we're very, very concerned about the outcomes of the infant. So we need good clinical data on the infant at the same time that we need data from the pregnant women. So as Susan was talking about, crosstalk between data systems is critical for that indicator. The second is that Gillian mentioned that we've done cognitive testing. And our cognitive testing on pregnant women suggests that they don't tell us what they're doing. And so getting a lot of false negatives in our results is very concerning. I just want to say someone did a presentation with the rescue agency, and they presented like rates as high as 20% in California, 25% in California. And I have no idea if that's right, but if it is right, man, we need to be getting on this. So I really just want to also say that we also need to do certain things when we collect data on pregnant women that are special, because there are some legal implications for them reporting that they're using illegal substance, and so there are all these things we need to do to collect that information. So that's definitely an area that we as CDC are prioritizing. And I just want to put a plug in before I wrap up on a second area that we've just started to prioritize, and I've seen talks on it here, is what are physicians doing? Like, we woke up one day and like the whole country had medical. Not the whole, I know there's a few states who don't, and we did a recent survey, and it was really shocking to see what the physicians feel are the indications, how many are doing recommendations, and what they're saying to patients. So that's another area where we think we need a lot more data, not just MDs, but all healthcare providers, including nurse practitioners, nurses, et cetera.
Yeah, and that's also critical because we want physician education, and there's a big gap in that right now as well, and I think in many ways that gap is being filled by industry, and we want to make sure that the information that's being provided really is an accurate representation of the data. And you heard from Dr. Grant yesterday that there's still quite a lot that we don't know, and that many of the states have indications for which there's absolutely no data whatsoever. Not to mention just the confusion sometimes between THC and CBD, or at least the not being very explicit about how they are different and what their potential uses may be. Hanan, did you want to say something about emerging areas?
Yeah, sure. I mean, some of the ones that we're interested in, I mean, obviously we're interested in breastfeeding individuals and some of the other areas that were raised, but a few others are building on some of the work that we've been doing on the medical side for a number of years is looking at adverse reactions or adverse events to cannabis, both for medical purposes and for non-medical purposes. Under the medical access system, the commercialized system that we've had for about 4 or 5 years now, we've been collecting that data, but we want to do that. We're actually doing that for non-medical use, and it's actually in our regulations that regulated parties, like the licensed to hold